Hello, I'm Dr. Lindsay King. I'm the Medical Director of Liver Transplantation at Duke University and the Associate Editor for the Clinical Liver Disease Series Liver Rounds, a case-based approach to clinical conundrums. I'm here with Dr. Daniel Pratt, the Director of the Autoimmune and Cholestatic Liver Center at Massachusetts General Hospital in Boston. He is the author of The Case in a Tight Spot. This case describes a 31-year-old with primary sclerosing cholangitis and ulcerative colitis who presents with a high-grade biliary stricture on MRCP. After multiple ERCPs showing atypical cells and attempts to evaluate for the presence of cholangiocarcinoma through ERCP, cholangioscopy, FISH, and next-generation sequencing, the patient ultimately underwent a modified pancreaticoduodenectomy with cholecystectomy, with pathology revealing both multifocal low-grade and one focus of high-grade dysplasia. This case certainly highlights the difficulty we face in screening our patients with PSC for cholangiocarcinoma and making a diagnosis of cholangiocarcinoma. I figured this would be a great opportunity to use Dr. Pratt's expertise to help guide us in some of these clinical decisions we face. So Dr. Pratt, as we see our patients with PSC in clinic, how do you counsel them about their risk of cholangiocarcinoma? Is every patient with PSC the same? Do they have the same risk, or are there differences based on the way they're presenting?
Yes, absolutely. So there are important differences, and I think that's important to share with your patients, but also I think clinicians need to be aware that the risk varies depending on specific patient characteristics. And the big ones to think about is the patients at the low end of the risk spectrum are our patients with small duct disease and pediatric patients, which is arbitrarily defined as less than 18 years of age. They seem to have no increased risk. So for them, it's something we can reassure them right off the bat that this is not an issue. But it's the rest of the patients that are a challenge. But even within all of our other patients, their risk varies depending on, at the very highest risk, those with dominant strictures and have concomitant IBD are at the very highest risk, whereas those who have large duct disease but do not have dominant strictures fall somewhere in between. So the challenge is knowing how to best manage every single one of your patients, but I would encourage clinicians to think about the individual and try to gauge what that risk might be.
And how do you recommend our patients with PSC be screened for cholangiocarcinoma?
Yes. So this is a challenging circumstance, something which is debated, quite frankly. But the guidelines, happily, the AASLD just came out with new guidelines, which will provide some guidance for clinicians. But I think, again, you have to think for the individual. So those patients at lowest risk, they don't need to be screened. If you have a small duct patient, no screening needed. If you have a large duct patient, they all should at least get screening with an MRCP. In my practice, an MRCP and a CA19-9 annually. But realize the AASLD guidelines, they were very careful in their wording. What they said was they should have imaging annually, ideally an MRCP, plus minus a CA19-9. So they've given the clinician quite a bit of wiggle room, but I would encourage clinicians to be a little more on the proactive side as opposed to the reactive side of this.
Okay. Has it been proven to be a benefit to screen our patients?
Yes, and there's actually, this is timely because it was just recently published an article. So in the past, what we had to rely on was a large retrospective review of a large cohort of PSC patients from the Mayo Clinic. And what they did is because they had so many patients followed over a period of time, some of them had enrolled in a cholangiocarcinoma surveillance protocol and some had not. And so they had the ability and the power to look at both groups. And what they found was those who were enrolled in the surveillance group actually had earlier diagnosis of their hepatobiliary cancers, were more likely to be able to have a transplant for a hilar cancer, and had significantly improved all-cause mortality. So that one actually seems to support quite strongly for surveying these patients. But recently out of Sweden, there was a study which was a prospective study where they took all-comer PSC patients and they put them in an annual MRCP and CA19-9 protocol, and they weren't able to show any benefit to that in terms of identifying patients at an earlier stage. But there was some real issues with that, and the one that I found most problematic was that there was great variability in what the clinicians were doing with the results. So in other words, it's not just simply going through the motion of doing an MRCP and a CA19-9 every year. How do you interpret those results in the context of the individual patient is so important. So I did not feel that there was anything definitive about that article, and I think we should continue to survey these patients.
Agreed. You mentioned the new AASLD guidelines or guidance for PSC and cholangiocarcinoma, and as you know, the new terminology for strictures. Can you
Yes.
fill our audience a bit in on those new terms that we are using?
Would be delighted. So this was, I think, one of the best things that the writing group did. So they took on the challenge of saying, let's come up with reasonable terms. And what's interesting is I like to feel that all members of our multidisciplinary PSC team now has their own term to use. That the old term of dominant stricture is actually in the realm of the interventional endoscopist. So it really was based on measurements that were taken from ERCPs, and those patients have to have a common duct stricture that's less than 1.5 millimeters, or a hepatic duct stricture less than 1 millimeters. The high-grade strictures now is in the realm of the diagnostic radiologists. So that's based on MRCP findings, and that's a reduction in the diameter less than 75% of the normal diameter size. And then I think for the clinicians, what we now use is the term relevant stricture. I think that's the one we all use, Lindsay, in terms of those patients where we're concerned they have progressively cholestatic LFTs. They're having pruritus, they're having other clinical symptoms that worry us, and in the presence of a stricture on imaging that is of concern. Those patients we now label as having relevant strictures.
And obviously this patient had a relevant stricture and then a dominant stricture on ERCP.
Right.
And had brushings and cholangioscopy and fish testing. Tell us about the current diagnostics and some of their shortcomings. Are they accurate? Are they sensitive, specific?
Yes. No, and then I know you know this as well, is sadly the issue we face is that a lot of our diagnostic testing, particularly in the pathology realm, has been less than satisfactory in terms of their sensitivity. When you look at it, brushing, cytology, and even with biopsies, they're often around 50%, which is just not good enough. That led to the development of FISH, which is now standard of care, or should be, in all centers when evaluating these strictures. And FISH has certainly improved that a bit, but it's still not perfect. I think what people also need to understand with FISH is it's not only a one-time result that's important, it's actually, can you replicate that result? And is there evidence of positive FISH, of aneuploidy or polyploidy at multiple sites in the bile ducts? These are the important things. And then finally, and this gets to our study, if I can jump ahead and talk about that, Lindsay, is that in our efforts, we felt that the holy grail of these strictures and diagnosing these would be if we could identify these strictures at a stage of high-grade dysplasia, as opposed to cholangiocarcinoma, and intervene in a meaningful way before these patients develop cancer, much like we can in the colon. That would be extraordinary. And so one of the things that we continue to study, but presented some preliminary data on, was the role of next generation sequencing and assessing these multitude of variants in oncogenes to look for important mutations in these patients that might then guide our therapies.
Yeah, that seemed to be important in this case and making a diagnosis of the dysplasia. Well, thank you for this summary and updating us on the new guidance and recent studies there. Anything else our readers should learn from this case?
No, I think it covers it all. And I appreciate the opportunity to chat with you.
Thank you.